So re-challenge with antibodies targeting PD-1L1 receptor after discontinuation or disease progression in solid tumors following a prior PD-1 or PD-L1 inhibitor is often practiced in clinic. Approximately, the frequency is around 20% of the patients receiving a re-challenged immunotherapy. So re-challenge in non-small cell lung cancer and hepatocellular carcinoma have shown some encouraging results. However, in metastatic renal cell carcinoma, the CONTACT-3 trial showed that addition of atezolizumab, which is a PD-L1 inhibitor, to cabozantinib did not confer an overall survival benefit compared to cabozantinib monotherapy in patients who previously progressed on or after immune checkpoint inhibitor therapy. However, in real world, data remains essential to be evaluated as the potential benefits of immune checkpoint inhibitor re-challenge in addition to cabozantinib in this setting may sometimes not apply because the patient population is not as rigorously selected and monitored during follow-up. So that's why we decided to have a real-world estimate of this situation. So patient-level data from de-identified patients with metastatic renal cell carcinoma, which were included in the Flatiron Health electronic health record de-identified database, was evaluated. So the Flatiron database is a longitudinal nationally representative database of US-based patients and includes real-world data from community practices and academic medical centers from 2011 through recent date. So our study consisted of US patients diagnosed with metastatic clear cell renal cell carcinoma who received first-line immune checkpoint inhibitor-based therapy from 2016 to 2022 and initiated a second-line treatment with either single-agent cabozantinib or cabozantinib with a PD-1 or PD-L1 inhibitor from 2017 to 2022. So we collected age, race, practice type, insurance, IMDC risk score, and prior nephrectomy at the baseline in the second-line setting. Our primary endpoints were real-world time to next treatment and real-world overall survival. We did propensity score matching at the second-line therapy using a logistic regression conditioning on baseline characteristics using a second-line start year, age, race, ethnicity, practice type, insurance, IMDC risk group, and prior nephrectomy. The cohorts were reweighted using matching weights. We had 68 patients in each cohort for this analysis, and we fit a marginal and multivariable Cox proportional hazards model comparing treatment groups on the outcomes of interest. In the multivariable analysis, we adjusted for the IMDC risk group. The proportional hazards assumption was checked using Schoenfeld's residuals. So overall, we have 12,285 patients in the whole cohort, of which 348 patients met the eligibility criteria. Our eligibility criteria included, as I mentioned, first-line treatment with PD-1L1 based therapy, and in second line, they should receive cabozantinib or cabozantinib with a PD-1L1 inhibitor, and they should not be enrolled on a clinical trial, nor they should be treated for another malignancy. So of these 348 patients who met the eligibility criteria, 280 received single-agent cabozantinib and 68 received cabozantinib with PD-1 or PD-L1 inhibitor in the second-line setting. Following propensity score matching, the median real-world time to next therapy was 8.5 months for patients receiving cabozantinib alone and 12 months for patients receiving cabozantinib with PD-1 or PD-L1 inhibitor. On casual hazard ratio, the cabozantinib and PD-1L1 inhibitors compared to cabozantinib monotherapy after adjusting for IMDC risk score was 0.74 with a 95% confidence interval of 0.49 to 1.12. It meant that there was no difference between both arms. Similarly, after propensity score matching, the median real-world overall survival was 20 months for cabozantinib alone and 21 months with cabozantinib in combination with PD-1 and PD-L1 inhibitor. So we again estimated the causal hazard ratio of cabozantinib with PD-1 and L1 inhibitors compared to cabozantinib monotherapy after adjusting for IMDC risk score, and it was 1.15 with a 95% confidence interval of 0.73 to 1.79, which again means that in both arms there was no difference in the real-world overall survival. So in the CONTACT-3 study, the results showed that there was no difference between the use of single-agent cabozantinib or cabozantinib with atezolizumab in terms of survival outcomes. Our results validate the findings of the CONTACT-3 results from a large real-world database and strengthen the evidence regarding the futility of the rechallenge of PD-1 or PD-L1 inhibitor in this setting. That is, we do not see any benefit with this approach of using a PD-1 and PD-L1 inhibitor. And CONTACT-3 results also showed that using a PD-1 or PD-L1 inhibitor in second-line setting, in addition to cabozantinib, may predispose the patients to more toxicity. With the CONTACT-3 results in conjunction with the real-world data, it can be stated that there is no additional benefit of adding PD-1 or PD-L1 inhibitor to cabozantinib compared to cabozantinib alone in second line, following PD-1 or PD-L1 based therapy in first line. With time, I believe more and more patients will receive only single-agent cabozantinib and may be spared from additional toxicity of immune checkpoint inhibitor in combination.